Our next speaker is Alpha Ibrahima. Sorry. Yes, from the hospital clinical point.
So, good morning, everyone. It's a great pleasure for me to share our research about colorectal cancer, entitled Propensity Score Analysis of Recurrence of Neutrophil to Lymphocyte Ratio in Colorectal Cancer. As we know, PSM is becoming more standard in controlling the covariate in the effect of confounding variable in retrospective studies. The difference between PSM and conventional statistic is that the PSM rely on the exposure model and the conventional statistic rely on the model that is being analyzed. So choosing the best covariate is very important in order to reduce the bias and controlling the bias and controlling the recurrence. So, neutrophilia, tumor growth and metastasis by some processes, including the remodeling of the extracellular matrix, releasing oxygen species, nitric oxide and arginase, which in turn suppress the T-cell response and increase the rate of mitogenesis. Previous studies have reported the role of the neutrophil to lymphocyte ratio, but little is known about its impact after radical rejection. And in this field, many neutrophil lymphocyte ratio and threshold have been used between the overall survivor and the recurrence-free survivor in the colorectal cancer, reinforcing the lack of consensus in establishing this value as a clinical marker. The question the intro address is how this data could be clinically useful, since patients with colorectal cancer are already going to get aggressive therapy or palliative care. Currently, most studies elucidating the relation between these variables are post-operative outcome are retrospective, and this type of study has the distinct limitation of non-matched subject, resulting in selection bias and confounding factor. So the aim of our study is to clarify the prognostic value of neutrophil to lymphocyte ratio in predicting the survival among colorectal cancer patients and the adverse effect of chemotherapy in patients with elevated inflammation. So this is a retrospective study of 280 adenocarcinoma patients who underwent D3 lymphadenectomy between 2010 and 2016. However, only 200 patients was retained after the inclusion and the exclusion criteria. So this is the study design, the flowchart of the study. As we can see, from 2010 to 2016, the initial onset colorectal adenocarcinoma. After the exclusion of 80 patients, we analyzed 200 patients. And using the cutoff of 3.5 that we get from the receiving operating curve, we divided the patient into two groups. Less than 3.5 was 115 patients, and more than 3.5 was 85 patients, using 6 covariates: age, BMI, CCI, tumor size, stage, and gender. After the PSM was generated, we analyzed 85 patients and compared these two groups. So this is the ROC curve for generating the cutoff. In generating the cutoff, the continuous variable NRR was used as the test variable, and the overall survival was used as the state variable. The area under the receiving cooperating characteristic was 0.68, and for all the patients, we retained 3.5 as we just saw in the flowchart. So this is the inclusion criteria. colorectal patient with adenocarcinoma that was diagnosed with colonoscopy and confirmed by pathology, and only patient who underwent 3D lymphadenectomy as the treatment method, and pathologically confirmed from stage 1 to stage 4. The exclusion criteria was perioperative chemotherapy, because in colorectal cancer, most patients who underwent perioperative chemotherapy have less than 12 lymph nodes. So this is very important when doing the postoperative classification, because we need at least 12 lymph nodes in order to do the staging, the TNM staging. And bowel perforation and obstruction was also excluded from this study, because the perforation can alter the microenvironment of the tumor. So this can explain sometimes the distant metastasis without the lymph node metastasis. So the palliative surgery also was excluded from this study, and the loss to follow-up was 20 patients. And the method we used was the statistical analysis, univariate, the Kaplan-Meier method, and the long-run test, the multivariate analysis using the Cox regression analysis. So as the result, for the recurrence-free survival, we can see that in the univariate analysis, the tumor differentiation, moderate and poor, was statistically different between the two groups. And the perioperative neutrophil to lymphocyte ratio superior to 3.5 was a risk factor. The lymph node metastases N1 and N2 also was a risk factor in the univariate analysis, but only the lymph node metastasis N2 was a risk factor in the multivariate analysis. So this is for the overall survival. As we can see, the gender female was a risk factor, and the tumor's differentiation, moderate, poor, also was a risk factor in the univariate analysis. The perioperative neutrophil lymphocyte ratio superior to 3.5 also was a high risk factor in the univariate analysis. In the lymph node metastasis, N1, N2 was also a risk factor. The distance metastasis, M1, also was a risk factor in the univariate analysis. So in the multivariate analysis, only N2 and M1 was a high risk factor. So this is the follow-up. As we can see, the blue line is the low and the green line was the high. So there is a difference between the two in overall survival. In about the recurrence-free survival, we have also a big difference, and the P was different between the two. So in the discussion, we know that in China, the Family Planning Commission of the People's Republic of China recommend perioperative chemoradiotherapy that is followed by TME, that is tumor total mesorectal excision for patients with T3 and T4 and positive lymph node metastasis. But this was discussed because in the exclusion criteria, we exclude patients who underwent chemotherapy, perioperative chemotherapy. And generally, previous studies have estimated that fewer patients who undergo perioperative chemotherapy have 12 or more or harvest lymph nodes. So this also was discussed with previous studies. In our studies, we have like 13 to 14 lymph nodes harvested after the postoperative pathological examination. That is greater than 12. The effect of the tumor on the nutritional state and systemic inflammation was also discussed. In previous study, Park and co-author previously suggested that the potential benefit of inflammatory agent in reducing recurrence and improving survival in patients with colorectal cancer. The lack of available immune therapy to maintain the enhanced immune status should be also explored, because this phenomenon has been linked to improved immune cell activity in cancer patients undergoing major surgery. So improving the inflammation and the nutrition is very helpful for patients undergoing the catabolic process after the rejection of the tumor. Inflammation has been considered the 7th hallmark of cancer, and manipulating the cancer inflammatory response presents an intriguing concept. The limitation of the study, of course, it was a retrospective study with a non-randomized controlled trial. Those selection bias might exist because of the small size of the sample, despite the attempt to use PSM to decrease the bias. Second, the cutoff should be more accurately assessed in future research. Finally, circulating blood cell-based prognostic biomarkers are not currently used clinically because of the lack of consensus regarding the threshold value. Many threshold values have been used in previous studies, so there is really a lack of consensus. In conclusion, the present study validated the use of perioperative neutrophil to lymphocyte ratio as a good prognostic factor that may improve the prediction of clinical outcome in colorectal patients, as we could predict warts, ovary survival, and recurrence-free survival using this parameter. The NLR could be useful in the routine assessment of primary operative colorectal cancer. Future direction for this study work is required to establish a definitive cutoff value for the neutrophil lymphocyte ratio in this field. Additional clinical studies and large prospective studies are also necessary regarding the determination of appropriate cutoff. The diagnosis of inflammatory disease, the presence of malnutrition, and the administration of anti-inflammatory agent can be useful in the outcome of cancer patients. Thank you for your attention.
One additional thing you might want to look at, overall survival is a metric you were using, but you might want to look at why people died.
Yeah.
And stratify them because they may not have not survived for the same reason. Some may be more closely related to the condition than others. So
Yeah.
that might even improve some of your statistics beyond where you have them.
Yeah.
So that was one thing. The other thing is, and we've noted this because of how we track the process of breast cancer diagnosis and treatment. A lot of times in the cancer, by the time the tumor is removed, there's a lot of inflammatory markers.
Yeah.
But a lot of them come from manipulation of the patient during the process of diagnosis and early evaluation, not from the disease itself. And it's very hard to separate what is due to the disease and what may be due to other factors, but it's important to keep it in mind.
Okay, thank you for your suggestion.
Yes, there.
Did you, did you look at correlating any of this to other known prognostic markers in CRC, like CA125 or CEA, and see if that yours is as good as those?
Yeah, we analyzed them in the univariate and multivariate, but there was no difference in the results. So that's why I did not keep them in the table. Of course, we have to analyze the CEA, the CA125. That's the basic thing marker for tumor. Yeah? We did that, but there was no difference. Yeah.
Any other question?
Thank you.